Thank you for the introduction. Today, I would like to present about ovarian stimulations. The first one is one of oral sessions presented from Dr. Weiss from the Netherlands. The title is Continued Treatment with Clomiphene Citrate in Subfertile Women with WHO Type 2 Anovulation who are not pregnant after 6 ovulatory cycles. World Health Organization Type 2 anovulation is common and it's normal gonadotropic anovulation. The clomiphene citrate is the first-line treatment, and National Institute of Current Healthcare states that the clomiphene should be used for up to 12 months. But there is lack of evidence for these recommendations. So the aim of this study was to investigate the efficacy of continued treatment with clomiphene in women who already have had 6 ovulatory cycles with clomiphene without conception. This study was a retrospective cohort study. The patients from fertility clinics of 4 hospitals in the Netherlands between 1994 and 2010. The study population includes the women from 18 to 41 years old with WHO type 2 anovulations, and they already have had 6 ovulatory cycles with clomiphene without successful conception. And they exclude the patients with tubal factors. And they followed of cycles 7 to 12. Clomiphene was continued in the same dosage. Their primary outcome was ongoing pregnancy, defined as the fetal heartbeat seen at ultrasound in 12 gestational age. And secondary outcomes were number of treatment cycles, multiple pregnancy, and miscarriage. In baseline characteristics, as you can see, the mean age is around 30, and BMI is relatively low, and almost patients were primary subfertility, and LH and FSH were normal level as we expected. And ongoing pregnancies per cycle of cycle number 7 to 12, we can see in every cycles ongoing pregnancies can see in every cycles. The range is between 3 to 15. The ongoing pregnancy rate was 31%, and among them, singleton pregnancy was 91%, and miscarriage number was 16. And ongoing pregnancy rate per cycle was 83, and median time to pregnancy was 9 months. And they analyzed the cumulative pregnancy rate, and we cannot see any plateau up until 12 months. And as we can see, the 12 cycles, the cumulative pregnancy rate is over 50. So they conclude that the continued treatment with clomiphene citrate result in a high percentage of pregnancies in women with WHO type 2 anovulation. Of course, if this result are confirmed has to be confirmed in a prospective setting. And continued treatment of clomiphene should be considered they conclude that the continued treatment with clomiphene after 6 cycles should be considered as the first choice. However, whether earlier use of gonadotrophine is really more cost-effective is unknown, and also the effect of adding IUI is still unknown. So now this group start to do a big study, the multi-center, the RCT in the Netherlands. So they randomized after 6 ovulatory cycles with clomiphene, and they want to see their live birth. Second topic is one of oral session presented by Dr. Gronewald from the Netherlands. The title is Increased Breast Cancer Risk After Multiple Implantation in IVF, a Cohort Study. Breast cancer is most frequently diagnosed cancer and is leading cause of cancer deaths among women worldwide. And experimentally, the estradiol and progesterone strongly involved in breast cancer tumorigenesis and established risk factor change lifetime exposure to these hormones, like early menarche or late menopause, low parity, and high age at first birth. In multiple pregnancy, estradiol and progesterone level was higher than singleton pregnancy. So intuitively, breast cancer risk should be higher after multiple pregnancy. However, the literature is still inclusive. 17 studies and 1 meta-analysis out there, but 4 studies reported significantly reduced risk in multiple pregnancy group, and meta-analysis showed no significant association. So, in addition to multiple pregnancy itself, they hypothesized that there is any maternal trait involved. So any specific maternal trait can be related to improved embryo implantation potential and related to breast tumor progression. So the vascular endothelial growth factor can be one of candidates. This group previously reported that the relation between the VEGF and the embryo implantation. So it can be one of factor, and VEGF stimulates angiogenesis at embryo implantation, and VEGF also involved in breast cancer progression. So they hypothesized that women with improved embryo implantation potential with a multiple pregnancy after the complete implantation demonstrate an increased risk to develop breast cancer. The complete implantation means every transferred embryo develop into baby. So the aim of the study was to investigate the effect of multiple pregnancy on breast cancer risk and embryo implantation potential on breast cancer risk. Between 1995 and 1996, they identified the large Dutch nationwide cohort of subfertile women who received at least 1 IVF cycle with controlled ovarian hyperstimulation between 1983 and 1995. They included only pregnancies over 24 gestational age. Miscarriages didn't affect the breast cancer risk. And they also included the higher order multiple pregnancies like triplets and quadruplets. And they excluded the women with breast cancer before first IVF or entering cohort, women who refused registration, and women with missing data. And they collected the data between 1997 and 1999. They got the risk factor questionnaire and informed consent. The questionnaire included the data on reproductive history and lifestyle factors, and they collected medical record, and they got the data of breast cancer incidence from the Netherlands Cancer Registration. Around 20,000 subfertile women were enrolled initially, and after exclusion, of around 13,000 women were available for analysis. Among them, the 38%, around 38% remained nulliparous, and 48% of women got singleton pregnancy, and 13% of women got multiples. And the breast cancer incidence were here. And they did the statistical analysis using Cox proportional hazard model, and they set the reference of the singleton pregnancies. And they set the two starting points of follow-up. The first starting point was the date completing questionnaire, and second one is the age at first IVF cycle. And they additionally analysis was the relationship between the breast cancer risk and embryo implantation potential. These are the results of the follow-up from questionnaire. The first starting point. Breast cancer risk was lower in nulliparous group compared to singleton pregnancy. And in multiple pregnancy group, the hazard ratio was 1.59, which is higher. And in higher order the multiples, in this group, the hazard ratio was much higher. It was 2.62. And in this analysis, they adjusted for age at filling out questionnaire and number of IVF cycles and height and age at first birth. Their mean duration of follow-up was 11.2 years, and mean age at breast cancer diagnosis was 46 years, and they analysis also for the second starting point, which was age at first IVF treatment. The result was comparable. The hazard ratio was 1.44. These are the results on the relationship between embryo implantation potential and breast cancer risk. In compared singleton pregnancy, in multiple pregnancy group with incomplete implantation, the hazard ratio was 1.31, but the multiples with complete implantation group, the hazard ratio was 1.86, which is much higher. And they also adjusted for age at first IVF treatment and number of IVF cycle, height parity, and age at first birth. So mothers of multiples have 59% increased risk to develop breast cancer. Specifically, the multiple pregnancy with complete implantation had a significantly increased risk. The hazard ratio was 1.86. This result supports a possible biological link between embryo implantation potential and breast cancer risk. But still, there is no reason for earlier breast cancer screening yet. The results should be confirmed in further studies, and the risk difference is not that big, and the identification of women with improved implantation potential is still difficult. The last topic is one of a poster presentation from Slovenia. The title is Morphokinetics of Embryos Acquired from Poor Responders aged 40 years and above, comparison between natural and stimulated cycle. Nowadays, the natural cycle IVF is commonly performed for poor responders. So they wondered that if there is a difference in the morphokinetics of embryos derived from natural cycles compared to stimulated cycle, within the group of poor responders over 40. They did the prospective study. They include 42 poor responders over 40, and they treated in 2012. Patients were diagnosed as poor responders according to their response to previous two IVF conventional IVF cycles. They include the patients with successful oocyte retrieval with 1 to maximum 2, maximum 3, and they did ESHRE. In the natural cycle group, there was 28 patients with 31 oocytes retrieved. After IVF, 27 embryos were obtained for time-lapse monitoring. And in the stimulated cycle group, 14 patients with COH with combinations of protocols, the agonist and antagonist, and they got 26 oocytes were retrieved. And after the IVF cycle in total, 23 embryos were obtained for time-lapse monitoring. During 3 days, cultivation images of the embryos were taken in 5-minute interval. They're using PrimoVision. And the timing of the disappearance of the PN, the formation of the cleavage furrow of the first and second mitosis, and the beginning of the 2, 3, 4 cell stage were monitored. The time interval were compared with Mann-Whitney test. Since the number was small. So they compared the time intervals of embryo development between the two groups. The time intervals, the fertilization to the disappearance of PN, and the first mitosis and 2-cell fertilization to 2-cell stage and 3-cell and 4-cell stage. As we can see, there was any significant differences between two groups. And they also compared of the time intervals in the subject of embryo without ovarian development. And the time interval of 3-cell stage to 4-cell stage, there was differences, but fertilization to 4-cell stage, there was any difference. So no significant differences were observed in morphokinetics of embryos between the two groups. So they concluded that the treating poor responders with a natural cycle approach or stimulation has no effect on the dynamics of embryo development. Thank you.
Thank you very much, Dr. Kim, for a very beautiful presentation. Yeah. So I wonder, is there any comment question from the audience? I think the breast cancer and stimulation and pregnancy was one of the best part in ESHRE 2013 this year. And as you all know, the breast cancer should be increased year by year, especially in the ESHRE regions. So I think this region meeting is common from the audience about breast cancer. Yes.
In your excellent talk. In your first several slides, you show that the use of clomiphene citrate up to 12 months. According to this abstract, do you think we need to have an age limit for this recommendation? Do you consider that age is important, or other factor is an important determinant? Or all our patients can be recommend to use 12 months of clomiphene citrate?
Yeah, just I think we have to really consider about the age. But in this study, as you saw before, that group is kind of easy group. As you can see, the mean age was 30, and the BMI is also the little bit lower, so that was the easy group. Before we decide to proceed the COH or IUI, So we have to consider the age, but we don't really know from this study.
So these are good prognosis patients. Mm-hmm. Okay, thank you.
Any comment or questions? Talking about the age, I think for the woman, the age of 37 should be a very critical period, because after 37 years, the intrafollicular count and the aneuploid rate was increased predominantly. So normally, if the age of 37 plus 13.5 years should be the age of menopause. So I think, but for those patients you present, which is sub-infertility group in this area and very young age. Yeah. Any comment or questions? Okay, if none, we will move to the next thing. We thank Dr. Kim again.